Welcome to the student of the 5th year at the Women Medical College on online ophthalmology classes. Today's topics is uveitis. I am Professor Dr. Lutfor Rahman, Professor of Ophthalmology at the medical colleges. Today's topics is uveitis. We start uveitis with definition. Uveitis means inflammation of the uveal tissue. Uveal tissue includes iris, ciliary body and choroid. Iris and ciliary body we call it anterior uveal part and choroid we call it posterior uveal part. When inflammation of iris, it is called iritis. When inflammation of the ciliary body, it is called cyclitis. When inflammation of the choroid, it is called choroiditis. For the treatment purpose or also the diagnostic purpose or also for observational view, we can classify uveitis in different way. One classification is anatomical classification. This anatomical classification is anterior uveitis, intermediate uveitis and posterior uveitis. When another is pan uveitis. Another classification is etiological classification. It is infective like bacterial, viral, fungal infection and non-infective. Non-infective, it may be associated with some systemic disease. It may not be associated with some systemic disease. Number 3 is Maghbazar syndrome. Maghbazar syndrome means uveitis associated with neoplastic diseases. This is the second classification according to the cause, and third classification is according to the onset of the symptoms. It may be sudden, it may be insidious. Another classification is according to the duration of the disease persist, that is limited duration. Another is persistent duration. Limited duration means uveitis is limited within 3 months or less. Within 3 months it is cured, or some uveitis it may persist more than 3 months. Last classification is clinical classification. It is very important for the student or as well as us. Clinical classification is acute, recurrent and chronic. Acute means sudden onset with limited duration. Recurrent means repeated episodes of inflammatory attack. Chronic means persistent duration lasting more than 3 months. This is the chronic inflammation. Anterior uveitis, our very important part is anterior uveitis. Anterior uveitis means inflammation of the ciliary body and iris. We call it anterior uveitis. Etiology, discussed previously, that is etiology, 50% of the cases etiology is not known. 50% of the cases etiology we can assess some causes. Causes is related to the some systemic disease. What are these systemic disease? This systemic disease, one systemic common disease is HLA-B27 related disease, that is ankylosing spondylitis, very important cause. Another is juvenile idiopathic arthritis, বাচ্চাদের এটা হয়. This juvenile idiopathic arthritis associated with uveitis, very common. Last is juvenile nephritis. Juvenile nephritis is also very common. These are the related disease, and some chronic disease may be associated with these uveitis. Number 1 is tuberculosis, syphilis and viral infection. Some Maghbazar syndrome, that is neoplastic, lymphoma and melanoma, it may be associated with uveitic disease. Some immunological depression, the HIV related uveitis may also be found. Some unknown causes like sarcoidosis, multiple sclerosis, drug-induced uveitis may be related to this. These are the causes we can find from the books or from the patient. It is the common for uveitis cause. Now we come into the clinical features of the uveitis. In acute uveitis, and acute symptoms may appear. Acute symptoms means acute inflammatory symptom, that is pain, photophobia, redness, watering, and watery discharge. These are the symptoms of the patient. With this symptom, we can't diagnose a case of uveitis, but for diagnostic purpose, symptom along with sign and investigation, everything is needed. In sign, we come in chronology, that is visual acuity. First of all, visual acuity is reduced. Why visual acuity reduced in uveitis? Because of the corneal haziness, aqueous humor haziness, pupillary reaction defect. For this purpose, visual acuity is reduced in case of anti-uveitis. Then we come into the congestion. There is typical conjunctival congestion here, that is redness in and around the limbal part, that is around the cornea. This is called ciliary congestion. Another two diseases we found this type of congestion. One is acute congestive glaucoma, another is corneal ulcer. This ciliary type of congestion is very important in case of uveitis. Then pupillary sign. Pupil have a typical presentation in case of uveitis. Pupil is constricted, sluggishly reacting and irregular. Pupil size is constricted, shape is irregular and sluggishly reacting. These 3 points you utter, it is very important for uveitic cases. Pupil is constricted, sluggishly reacting and irregular in size. But in case of acute congestive glaucoma, pupil is mid-dilated, vertically oval and non-reacting to light. These are difference in pupil in case of uveitis and in case of glaucoma. Then corneal sign, cornea normally looks transparent, but in case of uveitis, it is ground glass appearance, a bit hazy. Why hazy? Due to the accumulation of the inflammatory cells on the endothelium of the cornea. This accumulation of endothelial cell, we call it KP. KP means keratic precipitate. Then we come the anterior chamber sign. Anterior chamber is full of aqueous humor. Usually it is transparent, but when uveitis occurs, there is a huge inflammatory reaction and elimination of the inflammatory proteins. This protein and inflammatory cells in the aqueous humor, aqueous may be turbid. Turbid due to the accumulation of protein. Accumulation of protein, we call it flare, F-L-A-R-E, flare, and accumulation of cells, that is inflammatory cells like neutrophil, lymphocyte, monocyte, macrophage, like this. Then when flare, that is accumulation of protein is huge amount, we call it exudate. When this huge is mass enough along with huge cell, we call it hypopyon. Three terms here: flare, exudate and hypopyon, same thing along with inflammatory cell. These are the findings in anterior chamber in aqueous humor. We can examine with the slit lamp biomicroscope, we find all these things. Now we come to the iris. Iris have some nodules. These nodules are found in the chronic inflammatory disease. One is Koppi nodules, one is Busaka nodules. Koppi nodules found in the iris margin, Busaka nodule found in the iris surface. It is mainly in the granulomatous reaction. Next iris findings is posterior synechia. When uveitis started, there is starting of the posterior synechia means attachment of the iris with the lens. This posterior synechia is 1 point, 2 point, 3 point, and it is progressed like a circle. 360-degree posterior synechia when occurred, we call it cephaloceopupil. When this cephaloceopupil is formed, this pupillary area is occluded by the inflammatory exudate, we call it occlusiopupil. When cephaloceopupil occurs, there is a gradual raise of intraocular pressure, secondary glaucoma ensues. Then sometimes in chronic uveitis, there is iris have different colors, that is some black, some white. It is a sign of iris atrophy. Another term is in iris, it heterochromia iridis, means iris have different color, white color, red color, brown color. It is called heterochromia iridis, found in Fuchs uveitis syndrome. Another common iris findings is new vessel in the iris. it is found in the diabetes mellitus. It is also called rubeosis iridis. That is, iris have different findings. Posterior synechia, cephalosiopupillae, occlusiopupillae, iris atrophy, heptarchy iridis, rubeosis iridis, all have occurred in uveitic cases. Now come to the what about the intraocular pressure of the patient. Intraocular pressure when uveitis start, it is diminished due to the ciliary shutdown. When posterior synechia, cephalosiopupillae occurs, it is raised to form secondary glaucoma. Two types of pressure reaction here. Sometimes posterior segment findings may be found, that is in the retina, optic disc, macula have posterior segment findings. In retina, there sometimes retinal detachment occurs, then posterior uveitis, choroiditis occurs, sometimes cystoid macular edema, the fluid macular edema, CME, RD, posterior uveitis, these are the posterior segment sign. In short, iris sign is very important from the vision towards the posterior segment. All structure of the eyeball is affected with the inflammatory process of the iris. How we conclude the diagnosis? If we confirm the diagnosis, we have to find out the cause. In case of acute anterior uveitis with typical features, 50% cases cause is not known. That is why sometimes we need no investigations. As a result, we start treatment immediately without doing investigation. When treatment does not improve the disease process, then we do the investigation. What are these? For according to cause, we can do. If we think about it is a case of ankylosing spondylitis, we advise for the patient for X-ray of the sacroiliac joint and HLA-B27 blood estimation. These two investigation. When we think about it is a cause of syphilis, we advice for the patient for syphilitic serology, that is VDRL and TPA, Treponema pallidum antibody test. If we think about the disease is sarcoidosis, we advise for the patient X-ray test PAView along with ACE investigation, angiotensin converting enzyme, and we think that it is a inflammatory process of long way, then we advise for the patient for complete blood count along with ESR and C-reactive protein. Some special investigations, ANA, anti-nuclear antibody, only present in the SLE, that is systemic lupus erythematosus. Sometimes we advise for ANCA, anti-neutrophil cytoplasmic antibody, ANCA, ANCA, anti-neutrophil cytoplasmic antibody. In case of Wegener granulomatosis, it is present. Then detailed TB serology we can be done. That is, in case of when we suspect TB, we advise for the patient chest X-ray and MT test, and finally quantiferon TB gold test, and HIV serology also can be done. And these are the investigations we can do for a case of uveitis. Sometimes we need to do the ocular imaging. What are these? This imaging is B-scan ultrasonography, OCT, that is optical coherence tomography, FFA, fundus fluorescence angiography, ultra biomicroscopic examination. These are the imaging tests for the uveitic cases. Sometimes when treatment does not work properly, then we need to aqueous step. We do aqueous step and collect the aqueous humor, and with the aqueous humor we do gram staining, AB staining, Zimsa staining, staining for fungus, and send for PCR test and culture sensitivity test. All have done from aqueous humor, then reschedule the treatment. Sometimes we need to do the iris biopsy, vitreous biopsy, conjunctival biopsy. These are all are about the investigation of the anterior uveitis. Now we come to the treatment. Regarding treatment of the acute anterior uveitis, treatment is the treatment of the causes. What are the causes? That is associated with some systemic disease like tuberculosis, syphilis, ankylosing spondylitis and others. Then we treat it first, then when treatment cause is not found, then we treat in general. In general, we treat with two main drugs. One is steroid group of drugs, another is cycloplegic mediated group of drugs. So what are the steroid? Usually we use steroid is prednisolone, dexamethasone, betamethasone, loteprednol and difluprednate. These are the steroid group of drugs. What are the routes of administration of the steroid? Steroid is used in drops, by subconjunctival injection, by subtenon injection, by floor depots along with systemic. In systemic, it may be oral, it may be intramuscular, it may be IV, it may be intravitreal injection. In different routes, we give steroid. Frequent steroid drop, steroid injection, we can apply it for the KBOSIS cases according to the severity of the cases. Another question is asked to the student, that is, what are the contraindication of the steroid? Steroid cannot be given in corneal ulcer and in case of glaucoma. But side effect, what are the side effect of the steroid? In case of uveitic treatment, two common side effect every student should utter, that is the increased intraocular pressure, glaucoma and cataract formation. These are the common two side effect. Another side effect is corneal fungal infection is more and bone marrow depletion of the patient. These four are the common side effects. Next group of drug is cycloplegic mediatic group of drug. Cycloplegic mediatic group of drug, common drug is acpentolate and tropicamide. Here atropine is long acting, homatropine is medium acting, tropicamide cyclopentolate is short acting. Duration of action is very easy to remember. In case of tropicamide and cyclopento, action remains 2 to 3 hours, homatropine 2 to 3 days and atropine 2 to 3 weeks. But what are the action of this cycloplegic drug? Main action is to prevent the formation of the posterior synechia, to break down the newly formed synechia and to comfort the patient. How atropine comfort the patient? By relieving spasm of the ciliary muscle and ciliary process and iris muscle. By these three are the main function of the cycloplegic. Then sometimes when atropine and cycloplegia do not work properly or do not cannot break the synechia, we use a mid-decane injection. In case of mid-decane injection, we collect the adrenaline, atropine, steroid and procaine injection combinedly and gives it subconjunctivally or subtenonally. Action of the cycloplegic, three main action: to prevent the formation of synechia, to break down the newly formed synechia and to comfort the patient by relieving spasm of the ciliary muscles and iris muscles. These are the, when these atropine cycloplegic drugs cannot break the synechia, we give the mid-decane injection. Mid-decane includes the injection adrenaline, atropine, steroid and procaine. These four drugs we combinedly inject subconjunctivally or subtenously for subsequent 2, 3 or 4 days. Then we can get the final result. With these two drugs, steroid and cycloplegic drugs, along with treatment of the cause, we can save the eye from the uveitic inflammation. With these few words, I would like to conclude the discussion about the uveitis. Thank you very much.